XY DSD, we already discussed in the last session that it is more of an act of omission as compared to XX DSD, which are act of commission. So therefore, for having an act of commission, you have got limited ways in which things can happen, while act of omission can happen due to a numerous ways and numerous methods. So therefore, the etiology is much more varied in terms of XY DSD than XX DSD, and often evaluation may not be very easy from that regards, and that's why this remains a big diagnostic challenge. XY DSD can broadly be because of abnormalities either in the development of the gonad and the testis, or in terms of hormonal synthesis or action. So we can classify broadly in terms of dysgenesis and impaired DHT effect in that regards. So when we talk about XY gonadal dysgenesis, so if you remember it correctly, what we'll say is that the major genes which are initially involved are NR5A1 and WT1, which are responsible for the development of the bipotential gonad, along with the development of the adrenals and the kidneys. Subsequent to this, SRY plays a major role, and then we have SOX9. So these will be the four major genes which are involved. Plus, if you have excess of anti-testis genes, which include FOXL2 and DAX1 overexpression, can also cause abnormalities in terms of bipotential gonad development or maturation of the bipotential gonad into testis. So problems could be SRY, which is the most common form. If you have a SRY deletion, usually you will have a XY female. So as we discussed, SRY insertion is basically a XX male, while SRY deletion becomes a XY female in that perspective. Problems in NR5A1 with adrenal issues, WT1 in which you will have Danish rash, Frazier and other syndromes, abnormalities in the SOX9 which also has skeletal dysplasia. Along with that, you have got DAX1 duplication which can cause these problems. Now, whenever you have gonadal dysgenesis, basically it means that there is a problem in development of the testis. And this problem in development can happen in a wide spectrum, resulting in variable effect in terms of testis and the risk of malignancy. The worse the testis is affected, the highest is the risk of malignancy. So what is the most important determinant which will tell you about the risk of malignancy for a testis or a gonad?
Descent of testis.
Yes, so where it is the most important. So we discussed that the fact that the testis is descended basically means that it is able to produce insulin-like factor 3. It is able to produce AMH. It is producing androgens, and androgens are working. So which means it's a very functional one. On the other hand, if you have an abdominal testis, it means that there are a lot of issues which are there in terms of that. It's not developed well, and there is a high risk of having malignancy in that regards. So this gonadal dysgenesis actually is a whole spectrum. So we have seen patients who may just present to you with hypospadias to patients who will come to you with complete gender reversal. So mild forms, partial forms which will be there, in which will have an effect on the Sertoli or the Leydig cells predominantly, resulting in DSD, and the complete form which will result in a female appearance. So again, when we talk about XY DSD, we often talk about spectrum. So be it AIS, you can have a partial AIS in which there are certain atypical features. You can have a complete AIS in which you have a female appearance, or you may even have a minimal AIS in which you will not have any manifestation and it will look like a male with infertility. Similarly, 5-alpha reductase can have a whole spectrum, and gonadal dysgenesis can have a whole spectrum. So it's very difficult to phenotypically classify that, okay, this is the extent of DSD. This is more likely to be an androgen defect. This is more likely to be a gonadal defect in that perspective. Now, the malignancy risk, the more you are affected, the higher would be the malignancy risk in this perspective. Now, we'll go one by one. So, SRY deletion is an important cause of XY gonadal dysgenesis, but as against the SRY insertion, which is the major cause as far as the XX males are concerned, deletion accounts for 10 to 20% of cases, which means there are many more genes which may be affected in this scenario. It presents with a spectrum, so you may have a complete ovarian development, over testicular development, or even a testicular development depending upon the extent of its involvement. There is a reasonably high risk of malignancy which you need to be cautious about. NR5A1 defect basically is going to affect multiple pathways, including the development of the adrenal and the bipotential gonad. If you have a homozygous form, adrenal is also affected, while in heterozygous form, predominantly, you will have an effect which is there, predominantly the gonadal phenotype. When SF1 or NR5A1 was first discovered, it was often considered that this is a combined adrenogenital gene, but ultimately most cases actually have a gonadal phenotype rather than an adrenal phenotype in that regards. So manifestations are lower levels of testosterone and AMH. So whenever you have a gonadal dysgenesis, you will have a bicellular failure. So when we say bicellular failure, what will be the clinical manifestation of that? So if you have a combined Leydig-Sertoli failure versus a Leydig failure, what is the major difference which is there?
There is issues with the fertility also.
Depending on how early the Sertoli cell failure occurred, there may be presence of familial structure.
Yes, so if you have a dysgenesis, which means Sertoli cells also didn't develop, so basically it will mean that you will have Mullerian structures which will be present. So the major differentiating feature of a gonadal dysgenesis versus an impaired testosterone production, 5-alpha reductase defect or partial AIS, complete AIS is that you will have no Mullerian structures in Leydig cell problems. While in combined problems, you may also have a Mullerian structure which is present in that regards. Now this again can cause XX over testicular DSD. It importantly mimics partial AIS. Now this is important. Before genetic testing was coming in, often biochemical features and many patients have been shown for XY DSD that when you do a genetic testing, the diagnosis you get is quite different from the clinical spectrum. And when you talk about a particular diagnosis, your management will be difficult. So NR5A1, many cases were actually found to behave like partial AIS, and sometimes they were diagnosed as partial AIS and turn out to be NR5A1. So you need to have a genetic diagnosis to be 100% sure about diagnosis as far as the DSD is concerned, especially the XY DSD. Now, WT1 defect is associated with renal abnormalities, and we are well aware that these abnormalities may present just with nephrotic syndrome, renal failure, or they may present with DSD, predominantly a XY DSD. The manifestation include mesangial stenosis for Dennis-Dash syndrome, nephrotic syndrome for Fraser syndrome, and the Wager syndrome, which is associated with Wilms tumor, aniridia, and other abnormalities. So if you have anybody who comes to you with XY DSD, keep your eyes and ear open about renal disorders. That's why we are more cautious in terms of getting a genetic study in XY DSD, because you may be looking at things which may have long-term implications like a WT1 problem, including the renal or the subsequent malignancy issues in that regards. Other things that you can look at would be a urine protein, which will give you an idea about whether nephrotic range proteinuria is present or not. SOX9 is importantly involved in testicular development beyond the SRY, and it plays a major role in Sertoli cell development. And it also plays a role in skeletal development as well. So SOX9 defects will present to you with a spectrum along with skeletal dysplasia. So if you have skeletal dysplasia in a child with DSD, one is SOX9, other is. So if you have skeletal abnormalities in a DSD individual, what are the other two conditions you will think of? And that condition may present to you both with a XX or a XY DSD, Dhwani. So one is, of course, SOX9. POI defect presents with Antley-Bixler syndrome. A variant of it will have a problem in terms of collagen development and resulting in skeletal dysplasia. So that's the basic one. Now, DAX1 duplication, DAX1 is predominantly the antagonist of NR5A1. So we always talk about how DAX1 antagonizes its effects in the pituitary, in the testis, in the adrenals, in the steroidogenic transfer. So if you have too much DAX1, this is an anti-testis hormone, quote unquote, you can use that figure. This will cause testicular regression. You may also have associated adrenal insufficiency and hypogonadotropic hypogonadism, which is there. So to summarize the cause of XY gonadogenesis, you will have WT1, in which you will have a renal involvement with a risk of tumor and renal failure. So this is something you don't want to miss in anybody with XY DSD. NR5A1, you may have salt wasting, though this is less common in this regards, and this could be considered a differential of star. So star also will present you with a similar picture: low testosterone, low cortisol, low aldosterone. Similarly, if you have NR5A1, theoretically you can have both adrenotesticular abnormality, but often you only have a gonadal abnormality, as I have mentioned. SRY presents with complete reversal. 10 to 20% cases may have a SRY deletion. DAX1 causes pituitary adrenal involvement along with sex reversal, and SOX9 will have skeletal dysplasia. So these are the common manifestations in terms of XY DSD, which causes the gonadogenesis. Now, XY female is a specific scenario. So you have a XY individual who is a completely normal female appearance. They will usually present to you with primary amenorrhea. Now, what will be the clinical manifestation which you will say, okay, this girl has come to you with primary amenorrhea. This could be a XY female. Very characteristic feature.
So, what is if they have well-developed breasts but no pubic hair, then that is the scenario.
So I'm talking about in general. If I say that you see a girl walking to you with amenorrhea, and you see her and you say, okay, this looks like XY individual.
Height is not quite.
If they are tall, that's the other way around. They will actually have a male height. So we have had patients who have come to us with 175, 170. So they actually have a male height because all other genes which are determining the height are fine. The Y chromosome is working fine, the SHOX is working fine, and that's why the height will be tall. So tall girl with primary amenorrhea. In fact, we had 4 cases which we discussed in that time. Tall girl with primary amenorrhea, you think of AIS, as you rightly said, complete AIS as a possibility, some form of gonadogenesis, 17-hydroxylase deficiency. All these manifestations can present to you in that regards. So they will have, when we say XY female, we say complete female. So it's not that it's just a DSD. The ovaries have developed, which means the testis is not developed at all. There is, however, would be a gonadal failure. As XX male are infertile, XY females are also infertile because you need so many other genes other than a single factor. The common genetics include SRY and CBX defect and rarely NRA5. So these are so extreme that they will present this. So this is not what I was talking about in terms of AIS, because AIS is that everything is developed and then you have resistance. So this is like a complete normal female development. Some may in fact have periods and then stop periods. So it's like behave like Turner syndrome like scenario in that perspective. So management is pretty much like Turner syndrome in terms of the overall evaluation. What would you do to their gonads? Obviously, so gonadectomy. No. If you have a XY female who has a gonadogenesis, of course, this is a XY gonadogenesis. This you don't need to wait because this testis/ovary is not doing anything. So you have to remove it immediately. Gonadectomy is something which is recommended. Now, anorchia is an interesting condition. These individuals may present to you just with absent testis and a normal looking small penile development. Now, we discussed in detail that depending upon the time, the fetal time when the testes were damaged, you will have different manifestations. So what are the main cause of anorchia actually? So most commonly, it's a vascular insult in utero because of torsion or some other factor. So your testes are lost essentially. So anorchia, if it's happening very, very early, now very early, it's very unlikely, 6 weeks, you will have problems in both Leydig as well as Sertoli cells. You may have a Mullerian structure. Happening after around 8 weeks, you will have already the Mullerian structures have been removed. So you will have no Mullerian structures. But because you are not producing testosterone, you will have a problem in terms of hypospadias and atypical genitalia. Vanishing testes beyond 12 weeks will present with no Mullerian structure. They will show a normal looking penis, but it will be on the small side. So they will behave like a Kalaman syndrome, sort of a scenario like that child who presented to us with multiple pituitary hormone deficiency, and the small phallic size. So normal but small, micropenis basically. So bilateral non-palpable testes, considerations are of course that this could be a XDSD. So first time somebody comes to you with bilateral cryptorchidism and micropenis, the first thing you have to do is to look at a ultrasound to look for Mullerian structure. And second is whether it is anorchia or you may have a abdominal testis. Now, workup should include ultrasound for Mullerian structure, and as we discussed for undescended testis, you should always look at AMH and inhibin B. If you have undetectable AMH and inhibin B, it would indicate that it's an anorchia. You don't need to worry. In fact, I have seen few cases of anorchia, and whenever we see testosterone is 0 and FSH is high, even in 2 years, 3 years. So that also gives you a picture. But the recommendations are to look at AMH and inhibin B, which will give you the true picture. If your AMH and inhibin B are detectable, then that means that there is a functional testicular tissue. And in that scenario, you should ideally go ahead and localize it using a laparoscopic procedure. That becomes important from that regards. Now, persistent Mullerian duct syndrome, as the name suggests that your Mullerian duct are persisting, you have a normal male development, but you may actually have a undescended testis because the Mullerian structures may obstruct the descent of the testis. Now, theoretically, PMDS may happen if your AMH is either not being produced or it is not working. So, AMH deficiency or resistance. So, this is a scenario. The problem could be at the AMH gene or the AMH resistance. Mullerian structures will be there. You will have a mechanical cause of undescended testis in that regards. So, we have discussed a lot about this dysgenetic process and the loss of testis subsequently because of the problem in terms of vascular insert. The next, of course, is impaired DHT effect. We have had a full session, I think, on this disorders. So problems could be the testosterone synthesis or action. So quickly to revise, you may have a problem in the dehydrocholesterol, which will result in Smith-Lemli-Opitz syndrome, which will present with mild glucocorticoid and mineralocorticoid deficiency, with complete reversal, microcephaly, syndactyly, upward near. So these are the characteristic features you will think of Smith-Lemli-Opitz syndrome. Problems in side chain cleavage or star in a classic form will present to you with lipoid adrenal hyperplasia, in which you will have a slightly later onset salt wasting, typically around 2 months of life, along with a XY DSD. 3-beta-HSD, of course, will present to you with variable phenotype, in which you will have milder form of hypospadias because you have reasonable amount of testosterone along with salt wasting. Problems in 17-hydroxylase will present to you with hypertension. 17-beta-HSD will present to you with isolated testosterone deficiency, delayed puberty in girls, or complete reversal in boys as well. 5-alpha reductase deficiency will result to you in terms of discrepancy between internal structures and external structures. So, Wolffian duct-dependent structures will be normal, while the penile development will be defective with hypospadia, which you will see. There would be virilization during mini-puberty as well as puberty, which is there. Then, of course, you can have a problem of androgen insensitivity, be it partial AIS or complete AIS, and the presentation will vary subsequently. What are the causes, Dr. Dhwani, which cause pubertal virilization? Yeah. So the most classic presentation, of course, is 5-alpha reductase, but whatever condition increases testosterone production, if your 17-beta-HSD is defective, it will not be 100%. Let's say it's 95%. So that 5% will also increase. So you will have some virilization. Same when you talk about insensitivity to androgens, your 50 will not work, but maybe 500 will work. So once the levels go really high, you will have some virilization during puberty, which can happen. Now, LHCG receptor defect is an interesting scenario in which your LH and HCG both are not working. This will present to you with Leydig cell hypoplasia, which is isolated and predominant effect in terms of testosterone biosynthesis. So manifestation, of course, it may have a complete spectrum from a normal appearing female to somebody with DSD. You will have other development of epididymis and vas because FSH, everything else is working well, AMH is working well, low level of testosterone with high LH. This will be your diagnostic feature. Alternatively, if you're thinking of a XY DSD, in the setting of an individual who has got palpable gonad and no Mullerian structures, your testosterone level is low and you do not have salt wasting, then there are only two differentials which are there, either 17 beta HSD or LHCG receptor. So this will give you a good picture in that scenario also, and there will of course be no response to HCG. If you have a Smith-Lemli-Opitz syndrome, I've already discussed about this, you have reduced cholesterol synthesis and your manifestations will again be a complete spectrum. We have seen patients who come to you with complete female appearance versus those who may just come to you with micropenis as well. You will have upturned ears, rotated ear, microcephaly, syndactyly, and clefts which will be there. The lipid profile will be diagnostic. Your cholesterol levels will be very low and high 7-DHC will be characteristic of the condition. Star and side chain cleavage will present to you with severe adrenal lipoid, adrenal hyperplasia. Manifestations again can be variable. All level of hormones, be it androgen, aldosterone, cortisol, all of them will be low and the metabolites will be low. There will be no response to ACTH. 3-beta HSD, again we have discussed, you have peripheral action. So you will have intermediate level of testosterone. It will result in a milder defect with salt wasting and your levels of DHEA and 17-hydroxypregnenolone will be very high. 17-hydroxylase is the hypertensive variant. So you will have problems in terms of 17-hydroxylation. The manifestations would be again hypertension, spontaneous or thiazide-induced hypokalemia, analkalosis, and DOC and corticosterone levels will be high. 17-beta HSD3 basically again you will have everything normal. They are just the differential very close to the scenario of what we had talked about in terms of the scenario for LHCG receptor defect. They will have no salt wasting and isolated testosterone deficiency is what they will present with, complete reversal, and you may have some pubertal virilization which is seen. The characteristic feature is that you have got androstenedione which is not getting converted to testosterone. So when you are evaluating XY DSD, you have to look at 4 investigations: DHEAS, androstenedione, dihydrotestosterone, and testosterone. So if you have all low, you are dealing with Vani? Star HCC. If you have DHEAS high, everything low, 3-beta. If you have got DHEAS and andro high, you are dealing with 17-beta HSD. If you have got DHEAS, andro and testo high, DHT low, 5-alpha, all high, AIS. So these 4 tests will give you the diagnostic picture in that regards. Oxidoreductase is what we were discussing about as a cause of skeletal dysplasia. It's actually not an enzyme, it's an electron donor. So it will result in deficiency of 3 enzymes, 17, 21 and aromatase. And a combination of 17 and 21 will cause you XY-DSD with salt wasting, which will be there. It's usually milder salt wasting. Pubertal virilization may again happen, and levels of 17-OHP and progesterone will give you the clue. So just to summarize the serogenic defects, DHC7 will cause Smith-Lemli-Opitz syndrome with syndactyly and salt wasting. Star side chain cleavage will cause salt wasting with low levels of metabolites. 3-beta HSD will cause salt wasting with high pregnenolone levels. 17-hydroxylase defect will cause hypertension, high DOC and 18-DOC. 17-beta HSD3 may cause complete reversal, or it may also cause atypical genitalia also, depending upon how much is the deficiency. Your andro to testo ratio will be giving you the clue, it will be high. POR will cause salt wasting, and your 17-hydroxyprogesterone and progesterone will give you a clue. Now, 5-alpha reductase deficiency is basically the problem in terms of activation of testosterone to DHT. Now, what is the major difference in terms of the effect of testosterone and DHT on the androgen receptor?
DHT has a and longer half-life.
So longer duration of binding. Once it binds to the receptor, it binds for a longer duration, and therefore DHT is much more potent from that perspective. So here the problem is that your DHT is not being produced, so the local effect gets compromised, because during the stage of development, the peritesticular areas are based in a very high level of testosterone. The Wolffian duct maturation, the prostate development, and all the other factors are not really affected from that regard. So you have a normal internal structures which are there. You will have, however, DSD, and you may also have very significantly virilization in puberty. This is basically because as puberty happens, your testosterone levels increase a lot, and this will result in virilization. So a characteristic, if you look at the character of Shikhandi from Mahabharata, who was originally supposed to be born as a female and then went to the forest and came back around 10-12 years ago as a male. So this is a classical 5-alpha reductase manifestation which is there, which can be noted from that perspective. Now the testo to DHT ratio is more than 10 in that regards, which is often noticed in that scenario. Now androgen insensitivity syndrome, of course, is a problem in terms of androgen action, and you can have a whole spectrum of androgen insensitivity. The spectrum may range from a minimal AIS to a complete AIS. The problem is in terms of androgen receptors or the repeat of the triplets which are there. There is low androgen effect in pubarchy. Spectrum is complete, which is normal female, partial, which is DSD, and minimal, in which you will have a male appearance with azoospermia, which will be noticed. So if you compare 5-alpha versus complete AIS, the major difference is both of them can have spectrum. So they can all present to you with a micropenis and hypospadia to a complete female appearance. But the level of masculinization is more with 5-alpha compared to partial AIS. Second is you have got more virilization, much more virilization in puberty in 5-alpha, while in complete AIS, you will have no virilization, you will have more of a feminization because breast development will increase. While for partial AIS, you will have milder form of virilization. So, of course, in both these scenarios, the most important biochemical test which we talk about is the testosterone to DHT ratio. If you have got a high testo, which is not getting converted to DHT, the testo to DHT ratio is more than 10. We are dealing with 5-alpha reductase deficiency. If you have a testo to DHT ratio which is less than 10, we are mostly dealing with AIS in that scenario. However, biochemical criteria to differentiate all forms of X5-DSD, not just these two, are not very, very perfect, and often you will have discrepancies in terms of biochemical as well as clinical diagnosis and genetic diagnosis, which makes it difficult to differentiate, and therefore genetic diagnosis is recommended in most cases. Pubertal change, of course, is virilization in 5-alpha reductase, and in complete AIS you will have feminization. Very importantly, the gender of rearing is as a male in 5-alpha, because during the antenatal period they have been exposed to high levels of androgens, while if it's complete AIS, this will be more likely to be female. For partial AIS, we may consider, depending upon the level of virilization which is there. Mullerian structures will be absent in both of them. Management for 5-alpha is dihydrotestosterone topical application, and for complete AIS will be gonadectomy and estrogen replacement.